Well, good morning or good afternoon, wherever you're watching from. I'm Tim Anaya, Senior Director of Communications at the Pacific Research Institute, and I'm pleased to welcome you to our webinar today. Now, for those of you who aren't familiar with PRI, we're a California-based, nonpartisan, free market think tank with offices in San Francisco, Pasadena, and Sacramento. And in 2019, PRI formed the Center for Medical Economics and Innovation, which builds upon our decades of leadership in healthcare policy research by championing solutions to improve healthcare delivery through innovation. And today's webinar is part of our efforts to break down complex issues like drug pricing and demonstrate the potential that market-based reforms can offer patients and the US healthcare system. Now, if you're interested in learning more about our work, you can visit the CMEI website after our webinar, of course, at www.medecon.org. Now, a little bit of housekeeping before we begin today. So first, our webinar today focuses on a new issue brief that was released just today by our Dr. Wayne Weingarten, who you'll hear from in a few minutes, on the issue of rebate walls. And we'll be sending out a link to download the study later today. Now, after the presentation from our speakers, we'll be taking questions from the audience. So to ask a question, use the Q&A function at the bottom of your screen. It's somewhere about here in the middle. To submit your question, and we'll ask as many questions as time allows. Now, Dr. Weingarten will go in depth into the findings of his study in a few moments, and he's going to be sharing some of the savings that he's calculated, showing how patients could benefit through reforms to tear down these rebate walls, as the title of his study suggests. But we thought it would be best to start with the human side of things rather than the numbers. And we're so pleased to have Dr. Madeline Feldman with us today. Dr. Feldman is a rheumatologist in private practice in New Orleans, and she wears many different hats, including as president of the Coalition of State Rheumatology Organizations, as chair of the Alliance for Safe Biologic Medicines, and as a professor at Tulane University School of Medicine. And she's going to paint the picture of how rebate walls can negatively impact patients and health outcomes. So without further ado, Dr. Feldman, the floor is yours.
Thank you, Tim. And I'd like to thank PRI for having me on today. And I am a clinical assistant professor at Tulane. I wish I was, professor, but thank you for giving me a promotion. So we're here to talk about tearing down the rebate walls. Rebate walls affect patients, affect society, affect economics, but how they affect my patients, and I'm going to use the example of rheumatology patients, perhaps a rheumatoid arthritis patients. And for the most part, we're talking about the specialty drugs. The formulary essentially tells the provider, tells the physician, prescriber, what they can prescribe. And once you get through the generic drugs, and all of my patients take the generic drugs first, then we get to the specialty drugs. If there is a manufacturer that has such a large market share of that particular formulary, they can pretty much dictate what drugs get on the formulary, what drugs get kicked off the formulary. They can even dictate what drugs are on a formulary for a completely different disease state. And that's why it's considered a rebate wall. They can create a wall around all of their portfolio of drugs because the amount of money that they've been kicking back to the PBMs over the years has enabled them to take this stance. So consequently, if I want to prescribe a certain drug for a patient, I'll be forced to take a drug that is made by the manufacturer that has created the rebate wall. But if you think about it, the whole way of getting to the rebate walls have affected my patients. Utilization management tools such as step therapy or non-medical switching are the tools that have enabled the rebate wall to be built. Having a preferred drug list and essentially forcing prescribers to choose the drug that has kicked back the most money to the pharmacy benefit manager. And because these kickbacks are based on the list price, My patients are forced to pay their coinsurance on perhaps a drug with a much higher list price. So if we have a drug that costs $10,000 a month versus a drug that costs $5,000 a month, my patients would certainly benefit from paying their coinsurance on the lower price drug. But oftentimes the lower price drug is not preferred. When we look at it, and on the surface it looks great because PBMs tout the savings that their utilization management tools encourage. But the way I look at it is, if you have two dresses pretty much exactly the same, done by fancy designers, one costs $1,000 at 50% off, the other costs $100 at 50% off. Which drug do you get the most savings? And that's how PBMs sort of calculate the savings. So when they say we can save $1 trillion over the next 10 years with these utilization management tools, I would submit we can't afford those savings. My patients can't afford those savings. So in order to, and I think Wayne will go into the numbers, in a very easy way to understand, but the way I look at it is, in order to get rid of the rebate walls, we really do need to get rid of the system and the step therapy and the utilization management tools that have created the walls, so that I'll be free and my patients will be free to take perhaps a lower cost drug, a safer drug, and even sometimes a more efficacious drug. So yes, it hurts society in terms of, I think, how much money we have to spend, but it really does hurt the individual patients, particularly those with chronic illnesses that need these expensive specialty drugs. So I agree. Tear down those rebate walls.
Well, thank you, Dr. Feldman. Now, as a reminder, if you have a question for Dr. Feldman or Dr. Weingarten, use the Q&A function at about here at the bottom of your screen to submit your question. So next, I'd like to introduce our Dr. Wayne Weingarten, who is the director of PRI's Center for Medical Economics and Innovation. Wayne is also a senior fellow in business and economics. I mean, both of you really wear so many hats. I don't know where you find time to sleep in a day, let alone get all your work done. Dr. Weingarten's research work focuses on policies that support the continued viability and vitality of the biomedical and pharmaceutical industries, both to benefit patients and to grow the economy. Now, in non-pandemic times, Wayne is often on the road, traveling the country, speaking at groups and giving testimony. I know I'm always nagging him to give media interviews on economic and healthcare topics, and he writes regularly for Forbes.com. So with that, please welcome our Dr. Wayne Weingarten.
Thanks, Tim, and thanks everyone for tuning in. And this really is, and I think Dr. Feldman did such a wonderful job documenting just how troubling rebate walls are, and that was really one of the goals we wanted to do with our paper here, was to put in one place, start documenting all of the different costs that patients are bearing because of the rebate wall. And I think that patient approach is probably the most important thing that we want to emphasize. And so we step back for a second, and we can go to the next slide. I think it's very important for, when we think about the pharmaceutical market, to compare that to the way markets are supposed to work. Because the way the pharmaceutical market works, it's the complete opposite, right? We have in the US, in most parts of our economy, a competitive environment where manufacturers and businesses are trying to serve the consumer, right? We have that mantra, the consumer is king. And because we have that mantra, we actually have prices that are constantly being driven down. Think about how cheap computers and iPhones are becoming relative to where they once were. It drives productivity and it drives quality up. We don't have that function happening in parts of our drug market. We do have it in lots of parts, but when it comes to the rebate system and when it comes to particular rebate walls, our competitive environment has gotten skewed. The businesses, like the manufacturers, aren't trying to serve patients, right? There's all of this interference, and that interference, there's a lot of bad manifestations. One of those is the rebate wall. And what I'd like to do, I think, in order to really fully understand the rebate wall, we need to actually have a little bit background on the rebate system. So if we go to the next slide, when you have pricing for drugs, and there's a lot of confusion, people will often refer to, when they talk about the price of a drug, they'll refer to what's called the list price or the wholesale acquisition cost. And part of the reason people do that, it's like that old joke, the drunk is looking for his car keys under the street lamp. He lost the keys down the street, but the light is over here. And that's what we're doing with pricing in the pharmaceutical market, where we're looking at list prices because that's really kind of what's easily available. But from a manufacturer perspective and from a systemic cost perspective, that's not what's relevant, right? Because after the list prices are announced, there's all of those rebates that Dr. Feldman was talking about, other types of concessions as well. Those discounts give us the net prices, right? The net revenue that goes to the manufacturer, the net cost to the system. And if you see the chart here, what we're looking at is we're comparing list prices, net prices to overall medical inflation. And so when people talk about a drug pricing problem, they're often referring to the idea that list prices, you can see over the last 5 years, have grown significantly more than overall medical inflation. But the actual market cost of drugs are growing slower than that. And the difference is the excessive growth in rebates. They're actually connected, right? We have excessive growth in list prices in order to enable the excessive growth in rebates, which then benefit the PBMs. Insurers can use that to try to lower premiums for everyone. And manufacturers are going to get into the game in order to ensure they have the good placement on the formularies. So we have this very convoluted system. And because we have that convoluted system, we're then vulnerable to what's been kind of developed into that rebate wall. So to give us a formal definition, if we go to the next slide, when we're talking about the rebate wall, what we're talking about is, in effect, the manufacturers using those rebates and they're tying it to specified volume targets. Now, when you have a drug, and the rheumatoid arthritis and rheumatology is very vulnerable to these incentives, because what happens is you have a drug that can treat multiple indications and has large dollar sales. So now you have a tremendous amount in dollar terms of rebates being kind of paid off of these drugs because we've negotiated that large gap. Well, those large dollar sales, when you tie it to volumes, becomes a huge stick to any insurer, any PBM that tries to have a competitive product come onto their formulary. The loss of those large dollar sales, if you just get a little bit of competitive sales, will actually expose you to that huge gap that we show between list prices and net prices. And if we go into the next slide, which reports the IQVIA data, we can see that at the list prices, the WAC prices, we're talking about $671 billion in costs, but the actual net costs are $356 billion. So there's a huge gap here. Now, all of this would not be nearly as problematic if everyone had to pay their costs based on those net prices. The problem arises, and rebate walls become particularly problematic for patients because patients' costs, our co-insurance rates, are based on the list prices. They don't necessarily need to be, but they are. And because they typically are, what ends up happening is with these rebate walls, the rebate wall in effect kind of protects the market share for the large already dominant player. That dominant player has excessively high list prices enabled to those large rebates, tying the insurer and the PBM into kind of that one contract. That gives a high list price, which is driving up the co-insurance rates, right, for a patient. Everybody else in the system is dealing with the net prices, so they're doing okay. There's a lot of complications, but patients are getting the short end of the stick. So when we're talking about drug affordability problems, rebate walls are an important contributor because, in effect, we're locking in the high cost list price medicines, forcing patients to use these high co-insurance rates, to pay these high co-insurance rates off of those high prices. That, in effect, is the problem. The way we enforce that, and that's a lot of the things that Dr. Feldman was talking about on, if we go to the next slide, that will use just sometimes just blunt force to keep out the competitors. So we're just going to not let any competitive product on the formulary in order to ensure, right, the PBM wants to ensure that the preferred drug gets the volumes. If I block someone from the formulary, well, that ensures volume pretty well. We can also put them on less favorable tiers so that patients, perhaps they can get access, but now they have higher coinsurance rates, higher payments. So it's a much less favorable position that competitors, so we don't have fair competition. And then the issue that Dr. Feldman was talking about, the step therapy, which is a very typically used technique to block competition. You basically, for non-medical reasons, you're saying, okay, we're going to force you to use our preferred drug. And only if you fail on that drug can you get access to competitive product. And that creates delays, other types of problems. Prior authorization is another technique used where the physician needs to get permission from the insurer to prescribe the drug. All of these, and if we talk about kind of two outcomes from all of these types of tactics, one is impact on health, the other is the impact on costs. If we start with kind of the health areas, a little bit of a cost, but to me it's something near and dear to my heart. If we go to the next slide, is if we talk about its impact on innovation, right? We know innovation is costly. It's costly for originator products, but it's also costly, especially in the biologics area, for the competitive products known as biosimilars. So it takes a long amount of time, 10 to 15 years to develop a new innovative product, 8 years to develop a new biosimilar, hundreds of millions of dollars for biosimilars, almost $3 billion when you include the post-marketing costs to develop a new drug. So the rebate walls impact this because that's a lot of money and that's a lot of time. Time, in an economic sense, has value or has money associated with it as well. So you have a huge cost of capital that you have to cover if you're going to bring a new innovative product to market. And when you're trying to determine this, one of the things you have to look at is, well, what's the expected ability for us to cover those costs? If you know the existence of rebate walls is there and it's growing, well, that diminishes your ability to cover those costs of capital, which means the likelihood of you to start a new potential competitor, especially if you know there's already a first-in-class medicine that's there. So why should I go through the process of doing a new innovative medicine, or why should I go through the process of investing in a biosimilar when I'm going to get locked out anyway? So what these rebate walls are going to be doing, if we don't get control of them soon, it's going to diminish that incentive for innovation. We'll get less innovation in the future, which means our future selves, our children, all of us will have less access to new therapies. Not only can that improve our health outcomes, but there's a strong correlation, it's probably stronger than that, strong relationship between new innovative drugs and lower overall systemic healthcare costs. So we're losing all of these opportunities, or I should say more accurately, we're diminishing the ability for us to enjoy those opportunities because of rebate walls. If we go to the next slide, we're also experiencing costs today. Those are costs in the future, but there are also costs today. One of the things we talked about, a tactic, which is just blocking patient access to alternative medicines. And this data from drug channels shows that it's in fact happening, as we've been seeing the growth over the past close to decade of rebate wall kind of tactics growing. We're seeing the lists of formulary exclusions growing. So more and more products are becoming off limits to patients. Go to the next slide. What we also see is that the step therapy and the patient, the need to get prior authorization, those are growing, and those are connected to worse treatment outcomes, right? So if we look at one study, which talked about close to a 20% reduction in treatment effectiveness when RA patients, in this case, had to go through step therapy. So when we're using step therapy as a means to enforce a rebate wall, we actually have a direct connection between step therapy and reduced effectiveness in terms of health outcomes. So here's a rebate wall reducing our health outcomes. If we look at an AMA survey, prior authorization, 90% of physicians said that prior authorizations had a negative impact on care. So when we're using prior authorization requirements to enforce a rebate wall, at the same time, we're reducing the quality of care. So we have these negative impacts on health outcomes just from the tactics that we're using to enforce the rebate wall. If we go to the next slide, we haven't even touched upon the issue in terms of drug costs. But we know that there's a very strong relationship between the cost of a drug and patients' adherence to it. Right? So if we look at some data from the Kaiser Family Foundation, they're talking about 3 in 10 adults, right? 30% over the past year, and this was in 2019, over the past year, they did not take their medicine to some extent because of costs. So now we have that there's going to be, I should say before we go there, that lower adherence, not taking your medicines, that's connected to worse health outcomes, but also higher systemic costs. So we're going to have this indirect impact on costs or secondary impact on costs from rebate walls because in effect, they're making drugs more expensive. More expensive drugs leads to less adherence, and that reduced adherence worsens health outcomes and raises our systemic healthcare costs. What we tried to do in the study, though, if you go to the next slide, we wanted to look at the direct costs, right? We wanted to say, we know rebate walls are diminishing competition. And if we're diminishing competition beyond all the costs we just talked about, reduced health outcomes, higher systemic healthcare costs, we know that if competition is diminished, then prices are going to be higher than necessary. And because of the peculiarities of the drug pricing system, those costs are being borne primarily by patients. And in fact, because these tend to be our more expensive drugs where the rebate walls are forming, that this is a large part of that drug affordability problem. And as opposed to doing some of these silly things like drug importation or tying our prices overseas, what we need to do is fix the system that is preventing competition. That is a tried and true method of actually controlling costs, improving health outcomes, all those things that we see elsewhere in the economy that we know we can see in the healthcare system if we enable that. So just for time, kind of very quickly go through the next couple of charts, but each type of competition, regardless of the type that the rebate wall is inhibiting, we know that's connected to lower overall costs. So brand to brand competition, if we go to the next slide, if we measure prices correctly, we're looking at those net prices, not the list prices, account for the rebates. We're talking about effectively 25% reduction of the price of the branded product prior to competition. So even this, what they call follow-on drug development, you can still see a significant amount of price reduction from competition. Alternatively, rebate walls, by blocking that competition, are keeping prices 25% higher than they need to be otherwise. And I think the hepatitis C cure and the evolution of those prices, which you can see on the slide here, is a very tangible example of how brand on brand competition over time does in fact lead to lower prices. And we've seen significantly lower prices as more and more competitors to the original hepatitis C cure that came out in 2013, over time, more and more had come out. If we go to the next slide, we see the same type of, but to a much larger extent, benefits occur from generic competition, right? This is something I think when we talk about drug competition, often people think about generics. And the FDA has done several studies, this data being presented is from the latest, that shows that when you get more generic competitors, you get significantly lower prices. When rebate walls block this from happening, we're leading to much higher prices that patients out-of-pocket costs are going to be based on. And finally, if you go to the next slide, looking at biosimilars, it's the same thing. We've seen, compared to the prices of the originator biologic prior to the entry of a biosimilar competitor, on average, we're seeing about a 30% price discount. The largest is 53% basically for Zarcio. So I think those studies and the data on price and competition clearly show that when you block competition, you're increasing prices. If we go to the next slide. So what we wanted to do in the study is say, okay, how can we apply this to rebate walls to try to get our arms around the trunk of the tree, right? We know that patient out-of-pocket costs are going to vary depending upon what type of insurance you have, how expensive the cost is, exactly which drug you're taking. So to get a sense of that, what we did is we said, okay, let's run through the different benefit designs and let's look at the costs of expensive drugs, which we try to put around $10,000, $50,000, or $70,000, figuring that creates a pretty decent representative range of the cost of these medicines, and taking into account all the peculiarities of the drug market, the fact that patient out-of-pocket costs are based on the list price, not the net price. Taking into account that a branded drug would be on average a tier 3 for an employer-sponsored plan, and the average rates that those would have based on the Kaiser Family Foundation survey. Taking into account how Medicare Part D, right, their benefit design, and basically run different scenarios through that to say, okay, if we have a $50,000 drug, and that is using a rebate wall to block competition, then we know based on the potential, the prices from the previous slides, how much prices could be lower if that competition wasn't being blocked. And so we can compare the difference. And that's essentially what we want, what we did. And I'm going to go through the next couple of slides. There's lots of data, so I'll just kind of summarize it saying there's hundreds to thousands of dollars in average savings, regardless of whether you're Medicare, regardless of whether you're an employer-sponsored plan or infusion drugs, so you'd be a Medicare Part B. You can have tens of thousands of savings if you're blocking a large number of generic competitors. So here we have an employer-sponsored plan. When we round the numbers, if you're blocking generic competitors and there's 5 potential generic competitors that could be coming on against a branded drug, that's almost $25,000 in out-of-pocket costs that patients are paying needlessly. If you're blocking another branded drug from competing, that's about $6,500 to $6,700 in savings. If we go to the next slide, we're looking at for biologics. Those, again, the formula design is going to be slightly different for employer-sponsored plans. You're on the specialty tier now, but again, you're still looking at $5,000, $10,000 worth of savings. And going on to our next one, we see the same basic idea when we're talking about, if we go to the next slide, infusion drugs under employer-sponsored plans. Those benefit designs would be slightly different because pricing is probably based on ASP. But again, lots of savings are being denied. So regardless of the situation, patients on employer-sponsored plans where drug rebate walls are effective are being denied thousands of dollars in potential savings. Alternatively, they're being charged too much. And if you're on Medicare Part D on the next slide, the same holds, right? Here, the benefit design, whether it's branded or a biologic, would be similar. So we're going to present this all together, but Medicare Part D patients are being charged too much money for the out-of-pocket costs when a rebate wall is preventing competition. And the same thing happens in the last slide where we're looking at our Part B results. It's the same thing. So, and I know that's a lot of numbers in the study. If you go look at it, we can, if you like numbers, we can really overwhelm you with those. But I think going through all these scenarios is instructive because it gives us a sense that regardless of where you're coming from and regardless of, the benefit design, if you're taking if you're somewhere close to the average design, rebate walls are costing patients way too much money. And I think that helps support the concept that we need to reform it. Patients are being harmed both directly in terms of higher costs, indirectly because our health outcomes are going down, which is a problem in and of itself, but it also leads to higher systemic costs in the future from the worse outcomes. So if we go to the next slide, then we start talking about, okay, let's reform it. How do we reform these? My view is the best way to reform it is to go big. right? Rebate walls are a problem, but the rebate system is also a problem. And if we fix the rebate system, we would then have also fixed the problem of rebate walls. So how do we do that? We need to get prices that are transparent. To the extent that there are rebates, we have to have those benefiting the patient. Going back to the first slide, the reason I start off talking about competition has to serve patients, consumers. And in this case, those consumers are patients, and drug competition has to serve patients. We need all of the industry players competing to how they can best serve a patient, have that patient focused. And if we tear down the rebate walls and have prices transparent based on that net price, now we're allowing patients to benefit from all of these rebates, which really what we're saying is we're not having these rebates punish patients, which is what's happening now. In the last slide, if we don't want to go big, we want to just focus on just addressing the rebate wall itself. I mean, I think if you compare these to other markets, there is clearly anti-competitive practices going on. These tie-ins, or these volume tie-ins, in most other markets, the FTC would deem that as anti-competitive. And so there are legislative or other types of solutions that perhaps the state AGs could address, but we have anti-competitive market practices, and we could do targeted reforms as well that just address the rebate wall, which would help. Obviously, I think broader rebate reform would be the most efficient, but targeted, especially if it's more politically expedient, could significantly address the cost being imposed on patients. And I think that's the most important thing that we always need to keep in mind. And I'll close with this, that we need our markets, our drug markets, our pharmacy markets, to focus on serving patients. And if we have that connection where patients' interests are driving the market, then what we're going to be able to do is drive down these costs and get medicines, the right medicine that can best serve the patient's needs to them. And that's got to be the most important priority. So Tim, I'll turn it back to you.
Now you can hear me. Thank you very much, Wayne.
Can I make one statement?
Oh, please go ahead.
I'd like to make one statement. You know, the rebate wall is actually a consequence of the rebate system. And in the beginning, because I can remember when a new mechanism of action drug came on 7 years ago to the rheumatology segment, all we had were TNFs and other biologics. A small molecule came on, and they priced it the same as a biologic. And when I questioned why this was, if they did not price it there, the PBM would not allow them on the formulary. So I would submit in the beginning, it is not the manufacturer that's creating the wall, because there is competition to get on the formulary. But unfortunately, the competition is the highest price concession, not the lowest list price. So just as when you have competition to buy a house and everybody wants that house, what does competition do? You put in your highest bid. And that is what happens initially when those formularies are being constructed for perhaps a new disease state. Every manufacturer has to put in their highest bid, which is based on the list price. Therefore, competition in the beginning is like buying that house on the block that everybody wants. Everybody puts in their highest bid. It's based on the list price. So consequently, because nobody has a lot of volume, and then the volume is granted to the winner. And then every year, the amount going back to the PBM gets bigger and bigger and bigger. And then they've created the monster of a manufacturer that has 60% of their insureds. And if they try to put on a competitor, that money will be pulled back. But in the beginning, it's not the manufacturer, because they do compete to get on. But unfortunately, they're not competing, as you said, on their lowest price. They're competing on their highest price concession. So it's a monster that's been created by the rebate system. And the only way to reverse it, as you said, is to reform the system, which is going to be very difficult to do.
So questions, and once again, if you have questions for either Dr. Feldman or Dr. Weingarten, use the Q&A function that's right about there at the bottom of your screen. So Wayne, the most popular question we got for you, will the slides be available afterward? Do you mind if we send these out to everybody after the presentation today?
Oh, of course. And please, I was getting creative with the cartoons, so please excuse them.
One question that came in, and maybe Wayne, this is probably best directed to you. Can you explain in more detail how rebate reform would help to dismantle the rebate wall? And what are some of the other free market policy solutions that the incoming Biden administration and the new Congress should consider to eradicate rebate walls and bring about broader patient and provider choice?
Absolutely. I think the best way to think about that is I think we're talking about explicit reforms to the rebate system. Right now, I think Dr. Feldman said it perfectly, manufacturers are trying to please the PBMs, and they have to, otherwise they're excluded, right? So you have this middleman that's blocked basically the supply, and the consumer has this obstruction in the middle, and so you're trying to serve them. And so right now the rebate is in a way to basically get access to your customer. Now the rebate wall comes out of that because I love the house example, but what you have now is this winner take all situation, right? Where you start that process. I know if I win that, I become the dominant drug, and then I'm going to use those revenues to secure my position, and I don't have competition anymore. I blocked it all out. So it's that initial thing is winner take all. I'm going to go big, both on my list price. I'm going to go big on my rebate. So now it exists so the rebate wall can kind of form because of the rebate system. If we mandate that the rebates have to go to the patients, or if we go some sort of antitrust route that says this is anti-competitive behavior, right? So you can't do that, and you have that in other markets where the FCC would come and say, this is you're colluding. You're coming up with some. I'm not a lawyer, so I'd be careful with my terms there. But it is anti-competitive behavior if you don't allow the rebates to benefit anyone but the patients. Then in effect you're forcing them to compete on net prices. Once you're competing on net prices, the PBM or the insurer are never have to worry about, oh, if I have a little bit of sales here, that my rebates are going to fall apart. Their financial interests are now aligned with the needs of the patient, and so the whole ability of a rebate wall to block something out doesn't matter. Now we're competing on the net price, which is how markets should work. I'm reflecting my price, my value relative to where it comes, and doctors working with patients then can say, okay, where is this most appropriate? And they're making the decision. But we've empowered the doctor and the patient to understand the prices, understand the trade-offs, and make the decision that's best for the patient.
I think one added thing to the reform would be to not only make the rebates go to the patients, but to have transparency on the fees, because what has happened as the employers and the other plans found out about rebates, the rebates started getting reclassified as fees. And if you ever could see a contract, an old Express Script contract showed there were a cornucopia of fees that were tied to the list price. So what'll happen is you'll just get all those rebates will all of a sudden shrink, but the admin fees, there's been lawsuits where you were able to see what the fees are, they dwarf the rebates. So I think transparency should be part of the reform, not only on the price, but and they should be forced to use a flat, fair market fee, not one that's tied to a percentage of the list price.
And that's so important, that it's got to be the spirit of what we're saying here, that if you leave a loophole and you go down the fee route, we're not going to get the outcome that we're looking for because you're violating the spirit, but obeying the letter.
So the Supreme Court made our webinar even more timely today. And here's a question. Given today's Supreme Court decision, how can states create PBM reforms to address the rebate walls?
Well, I'll take that. CSRO has been a leader in the rheumatology space in helping states pass step therapy legislation, non-medical switching legislation. The pharmacists in Rutledge v. PCMA actually are getting gypped out of a lot of money from PBMs. And so the question was, could this state legislation apply, have jurisdiction over ERISA plans as well, which are a lot of patients out there work for large companies that are self-funded. So this decision today from the Supreme Court lays open now the ability for states to actually add protection to ERISA plans, not take away, so that if there is step therapy legislation, for example, was passed here in Louisiana that protects patients, you actually need a law so a physician doesn't have to make a patient take a drug that they've had a side effect to already. And that's actually the truth. We have to have legislation to say, I'm sorry, PBM, my patient is not going to have to take that drug you're forcing them to take because they broke out in a rash or because they had anaphylaxis. So now those same laws will apply to the ERISA plans. And that is a big win for consumers around the country. What happened this morning? It was unanimous, by the way.
Unanimous 8-0.
Yes.
Yes, 8-0.
Another question, how do you respond to the PBM argument that they are using the rebates to reduce the overall price of drugs to consumers?
Where do we begin? I will tell you that when I did sort of testify or make comments before the Health Insurance Subcommittee for Energy and Commerce, sitting next to me was the representative from PCMA. And after my comments, Chairwoman Eshoo asked her, Dr. Feldman said, you choose higher priced drugs. And she kept saying, well, they're lower cost, and it went back and forth, cost, price, cost, price. She finally just said, I don't care if they're lower cost, are they higher priced? And she said, yes. So if we have a drug pricing crisis in the United States and our patients are paying their coinsurance on the list price, and we have PBMs admitting they're choosing higher priced drugs, does any of that make sense? How can you lower the price, the cost for drugs, if they pick a higher priced drug to be on it because it makes more money? There's some serious issues in as you were talking about, anti-competitive, no transparency, and the patients are the ones that end up paying the price, both in their health and their pocketbook.
Yeah, I mean, I think when someone won't let you even see the fine print that nobody reads, something nefarious might be going on. And I think part of it also is there's a little bit of just follow the money, right? If part of the argument is that we're using the rebates to lower everybody else's premium, right? Well, that money has to come from somewhere, right? And where it's coming from is the patients who require high expensive drugs, which, right. So in fact, that the patients that we're caring about, the ones that are dealing with a disease that has a high cost drug associated with it, have to be subsidizing everybody else because they're getting this money that they're reducing everybody else's costs from. And money doesn't, just magically appear. Somebody has to be, there's another side to that transaction, and that has to be higher costs. So I think if you just follow the money, for a fact that their argument, there's something wrong with the argument.
And I think it was a few years ago, Drug Channels had a bar graph showing where rebates went to. Did they actually lower premiums? And no, most of it went to, cutting down on the drug spend by the employers. And you can't blame them when the PBM is putting $1,000 dresses on the formulary because they save $500. They don't put the $100 dress where that same drug would only cost the employer $50, but they can't tout that they saved $500. So we need to make sure that either the patients or premiums get to come down with all of these price concessions from the manufacturers.
Oh, Wayne, this next question I think is for you, and you can channel your inner Sally Pipes as you answer this question. How much of the issue with rebate walls here is attributable to our private healthcare system? If the U.S. were to adopt a single-payer healthcare system, how would things be different?
Well, if we had a single-payer system, it would be completely different. I guess there's two ways to address this. One Is this because of our system? Well, yes, right? We have some huge inefficiencies in our healthcare system, one of which in the drug markets is how our rebate system works, and we need to fix that, and we need to create a patient, a system that focuses on the patient. So that needs to be achieved. If you move to a single payer system, what you then end up with are price controls. And by definition, and actually Sally wrote a wonderful piece, it was just on Twitter, it was in Forbes, I should say. I saw it on Twitter, but it's on Forbes, where she's talking about the cost of healthcare in Canada. And that's really one of her expertise. And she's explaining that, in Canada, right, they have price controls on drugs. They also have access to about less than 50% of all new drugs, where we have access to 90%. You have long waiting lists. You have, in effect, lower quality of care when it comes to necessary treatments. And she tells us stories about, patients not getting colonoscopies that could actually save their life, but they don't get it in time. So there's all sorts of other costs that come about when you impose price controls in terms of reduced access. At the same time, if you look at the UK, you see there's a doctor shortage. Why? Because there's price controls on doctors effectively. And so they have a shortage of physicians. Those types of shortages are going to impact the quality of care and creates a large number of problems. So you're creating a whole new set of problems for yourselves by doing that. I should also say, by the way, in terms of just access to drugs, Canada has a whole website devoted to what drugs are approved, but you can't get because they're just not on the shelves. And that's a whole other problem that you would have. So your doctor can prescribe you the medicine, but if it's not in the country, you can't buy it.
So I think we have time for one more question, and I think this one would be a good last question for Dr. Feldman. How can physicians and their patients navigate the current system and the current rebate wall problem to get access to the best medication for their underlying condition?
Well, if we're forced to use what's on the preferred drug list and it isn't correct for the patient, unfortunately, the drug has to be prescribed and then has to not work, and then we can move on. There are samples in our office to tide patients over while waiting to see if another drug doesn't work. There's all kinds of workarounds, but unfortunately, they don't necessarily build the kind of trust in the physician-patient relationship that's needed. And this is very sad to say, the first question I have to ask after perhaps I explain to a patient, that they have rheumatoid arthritis and the various drugs we can use is, what's your health insurance? And that's sad that takes precedence over the doctor-patient relationship. So I think the way that we navigate is to try to change the system and try to make it so that the doctor-patient relationship, and of course, safety, efficacy, and lowest price have to take precedence. So we need a system that fosters that. And let me tell you, we do whatever we can, whether it's staying on the phone for 2 hours for a peer-to-peer, sending in 5 or 6 different appeals. I mean, we fight tooth and nail for our patients, and ultimately we get it for the most part. But if we don't, we figure a way to work around it.
Well, with that, I want to thank Dr. Feldman and Dr. Weingarten for your time and expertise today. I mean, I thought what a fascinating webinar we had today. And I want to thank all of our attendees for tuning in today. You now probably know more about this issue than you ever thought you would. I know I do. As I mentioned at the beginning, stay tuned later this afternoon. We will send out an email to everyone who registered with a link to download the study and also to Wayne's PowerPoint presentation. And again, if you want to learn more about PRI and the work of our Center for Medical Economics and Innovation, visit our website. It's www.medecon.org. Thank you once again, and good afternoon to everyone.
Thank you.